All right, let's just go ahead and jump right in. We don't have an awful lot, so maybe we might get done early. But welcome everyone to our October 28th Trauma Administrators Committee meeting. As was stated before, we want to make sure everyone signs in. We'll put the sign in code back up so that you can get credit for your attendance. Our first order of business is approval of the January meeting minutes, actually. So hopefully those were sent out. So hopefully everyone had a chance to review those. And if so, then I will take a motion for that approval.
Motion to approve.
Okay, I've got a motion to approve the minutes. Is there a second?
This is Angela. I second.
There's a motion and second to approve the minutes from the January 22nd, 2024 meeting minutes. Any discussion? All right, then please show your vote by saying aye.
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 Oh, aye as well. Any opposed? All right, those minutes stand as approved. Next on the agenda is our Trauma Commission update. So I'll turn it over to Dr. Medeiros and Liz.
That sounds great. I'll go ahead and start, and then Dr. Medeiros can, if she's got anything to add, she can fill in. I know we haven't had, because you all had the workshop at Chateau, and then we canceled the November or the August meeting because we had the other workshop for all the finance groups. So actually it's been a minute since this group has gotten together, but I do have just a few key updates to share with you. One is that if you all remember at the legislative session this year, the 61 million ask, okay, we did get 4 million. We did not get 61 million, but that was still a huge win to get 4 million. I think there was a little bit of sticker shock over that. But the data that Dr. Ashley and I and Dr. Medeiros worked on together, Dr. Ashley actually put that into an abstract and presented it at the American Association of the Surgery for Trauma at AAST, otherwise known as, in Vegas. And that was actually accepted and presented there. So really powerful now that, you know, it's got some sort of academic muster behind it, if you will. So, and we had several Georgia presenters. AAST was held in conjunction with World Trauma Congress. Usually when AA goes to the West Coast, World Trauma links up. So we had some nursing tracks there, myself, Kyle Gibson from Northeast Georgia, and then Shepherd Center was represented. So, so we had a great showing. So that was a real success. In addition, Dr. Ashley also presented an abstract on the work that's being done with GQIP in terms of that work has really resulted in a significant improvement in Georgia's risk-adjusted benchmarking. Now, from an ACS TQIP perspective, it really just is level 1 and level 2 centers that are in that aggregate database that is what we call the collaborative. But we are very inclusive with GQIP in terms of including level 3 and level 4 centers. It's just that they're not included in the risk-adjusted benchmarking yet, but we are working. That's a very exciting update, is that Gina is working with Arbormetrics, which is our statewide risk-adjusted benchmark program, which is why you all submit data to us in addition to DPH, because we are building the risk-adjusted capability. For the last year, since we stood up the database, it's mostly been you know, just some metrics on time to definitive care. We were looking at hip fracture, but nothing risk adjusted. So, so we're very excited to move into that space, and hopefully it'll be a little bit more contemporary data for you. For those of you who've been in around TQIP for a while, you know that you don't get your risk adjusted benchmark report until about 18 months later. So you really can't do anything about it at that point. So it would be nice to have some more contemporary information to really drive improvements at your centers. So we're in full swing in preparation for the upcoming legislative session and have already submitted our preliminary FY26 budget. We've met with OPB Director Dunn, as well as our Senate budget analyst. Just to let you all know, I think that, we've been told that money is tight and there probably is not going to be additional money this go around. And we recognize that after looking at that stabilization proposal, that it's probably going to result in needing another funding mechanism. So ongoing talks about that. We have a little while because that has to be a constitutional amendment. So we're not in a time frame where we can do that right now. So we're going to kind of step back and really think about what next steps are on that. We have sorry, having trouble reading my own notes because it's a little small here. So in response to some of the findings from the ACS System Consult and Rural Focused Review, we did end up conquering, and for those of you who were at Chateau Alon, you heard the presentation on our rural resource needs assessment. We're actually going to bring those results back to those folks who participated in that survey, most of which were not trauma centers, and really talk about how we can bolster up the community, the rural community, and just, make sure that, first of all, we heard them correctly, and that what we think are maybe some potential solutions are actually the right solution. So we really need the stakeholders at the table to kind of drive that. So, and this really impacts all of you on this call because many of you are getting transfers from the rural facilities. So we need those patients, we need to understand what some of their barriers are and really need to help them with their training needs and maintaining skills, competencies, and all those really important things so the patients can have the best chance when they get to you guys. So excited about that. That's November 4th and November 7th. So, of course, if anybody's interested in any of that, we can pass the results of that back out in case folks are interested in that and you'd like to see it. And then the last two things are that, or actually last thing, we have our next commission meeting scheduled for November 21st, and that will be in Cordele, Georgia at the State Office of Rural Health. That meeting now always coincides with National Rural Health Day. So we like to make a real, a sort of, big thing about rural and make the focus on rural since that has been a more recent focus for the commission, thankfully so. And I think that's it, Dr. Walker, unless anybody has any questions, or Dr. Medeiros, unless you have anything you'd like to add to that.
No, I think you covered it really well. The only thing we might want to mention is the second half of the TCAA finance workshop and the upcoming financial dashboard that you're sending out, just so the administrators can be aware of it in case there's any barriers to the programs being able to access the information to be able to complete that dashboard.
Yes, that is actually under our new business, but I am happy to launch into that right now if we want to, unless Dr. Walker wants to. The only other thing, unless folks have questions, is Gabby's going to give an update on the PBP Workgroup.
I think we can proceed. Liz, with your additional finance update.
Okay. Great. Gabby, if you can pull up that worksheet that I sent out to everybody so they can see it, that'd probably be helpful. Thank you. Thanks so much. Okay. So we have our second of the two webinars. I just want to make sure everybody's clear. The next webinar that's scheduled for November 5th, which is next Tuesday, is not a repeat of the first one. It is going back. You guys gave us some great feedback on the webinar evaluation. Thank you so much for that. We're going to address a lot of your questions And then we want to go over this sheet with your finance teams to make sure that everybody understands what's required. And mostly, since this is the first time we're working through this, we want your feedback on, this isn't clear, this didn't work. We asked everybody to pull a couple of cases to at least try to practice and go through this. It's pretty straightforward. But if it's not for you or your teams, we want to hear about that. We want to know what it is. So, and we did put in the note that you'll see in the columns there, it's asking for cases from January, February, March. This first go around is just a couple practice cases until we talk about this a little bit more on the webinar. So essentially what this is attempting to capture during our stabilization proposal presentation to the legislators, some of them were pretty savvy on trauma activation charges and had questions about, why do trauma centers need all this readiness money? Don't they get money for activations, which is great if it works. I know a lot of you are not having, I think somebody is unmuted. If you can mute your line, I'm hearing a lot of additional chatter in the background. Thank you. I think a lot of folks are not as successful with this. So we would love some way to kind of quantify that, because I think there's this thought out there that, centers are kind of getting rich off of activation fees. And I know some of you, despite your best efforts, have not been successful in getting any of these claims paid. So the first thing, though, is to figure out, are we setting up the claim correctly so that you can get paid for it? And the two things that Val went over on the first part of the webinar really focused on that field locator 14 type 5. And I know this sounds so basic, but this is really just how the patients are registered. And somebody a decade and a half ago thought it would be a great idea. Let's make sure that the trauma centers that are admitting trauma patients have on that patient type, which field locators it's just a registration function, but there are several selections, and one is like, I think, outpatient, one is inpatient, one is emergency. There is a trauma there only to be used for trauma patients for trauma center billing purposes. So on that field locator 14, so first thing got to do is figure out if you have that, or where that is in your billing system. So then you got to make sure that the type 5 is being selected. So that's really the first thing we're trying to do. And then the second thing is, of all of your activations, for the ones who had prior EMS arrival notification, because that's a differentiator in terms of billing. If they did have prior arrival notification, you can use that 68X code, and the X is just whatever level trauma center you are. So if you're level 1, it's 681. If you're level 2, it's 682, and so on. And then in addition to that, there's the ED service level charge, which is 0450. And we want to make sure that both of those are captured, because the 0450, that was a learning moment for me. I didn't realize that 68X and 0450 go together, but they do. But if your patient didn't have pre-arrival notification, they can't have the 68X, just the 0450, then your activation fee on top of this. So the first thing is to just figure out, of all of your activations, the important thing is, Jennifer Ward from TCA wanted me to remind everybody, you have to have had a response. So if nobody showed up, you can't charge for the trauma team activation. So many of you I know have different tiers. You have as many as 3 tiers. If you have more, we can worry about that later. But for right now, we've given 3 spots on here for 3 tiers. And you'll see, again, starting with row 15, you're going to collect those number of tiers in each level. You'll have your total. Then you go on to the next one, which is just your sample. The reason we want to kind of get to know what your sample is because, it's going to be impossible right now, especially for those of you not doing anything like this, to review each and every single case. But if we can attribute what percent of that and what success you're having with that percent, that in and of itself would be meaningful. And then anything in here that has a formula, like for the KPIs, it's all plugged in with a pre-entered formula in Excel. So all you need to do is put the numbers down on there. So So all of your, in the next section, I'm looking at row 20 here. Your sample for financial analysis will be your, again, your tier 1, your tier 2, the number of the total that you selected for sample, and then plugged in there will be your sample size. So you see there were 20 there, so that was about 27% of the 73 total activations that were available. And then in order to figure out whether the 68X code can be coded, you have to know if there was pre-arrival. So hence row 25 there is the number of activations where there was a pre-arrival notification, and then the number without pre-arrival notification. So from there, the next section is the key billing elements. And so there's that on row 28, there's that FL14 type 5. Was it captured correctly? Because that's something that, that can be a key success thing for folks. Like if that's something that you're really struggling with, that should be kind of low hanging fruit to be able to fix that. So, so for this one, there were only 12. And then the next one would be the number of charges under 68X, and then the number of charges under 0450. Again, remember, everybody should have the 0450, so it's not just the ones that didn't have pre-arrival notification. And then again, your total number having either 68X or 0450. And then again, you have your KPIs will be preloaded for you. And Gabby, if you can scroll down, then we added a couple boxes since we're asking for folks to develop their trauma finance PI team. We want you to kind of identify some OFIs around your FL14 type 5 capture. That's in the like 42, 43, 45 boxes there. And then the same thing for your responses for getting 0450 and 68X. What were some of the challenges that you encountered, and any action plans? So this is really to help us figure out, how can we tailor the education, because it's from the feedback we got, you're all on very different places in this. Some are really aggressively reviewing claims. Most just don't have anything specific to trauma. They had something for other service lines, but not for trauma. So I think this is some low-hanging fruit here that we can really improve, and then hopefully share at one of your meetings. So all of your finance team members and your trauma program folks who attended the webinar got this form with instructions to do a few test cases, so we could just make sure that this works and we can go over it on the webinar. In addition, as I said, Val is going to cover all of those questions that came in on the evaluation and the things that folks wanted. Namely, it seems like a lot of folks were interested in claim denials and critical care charges. So we're going to just reiterate, we're going to retouch on some of those things, and then I'll walk through this again. And then just a reminder, this will be added to the performance-based pay for your next contract. And so, so we want to get this worksheet kind of as tuned up as we can to make sure that everybody is good with submitting it. And, we're not looking for any kind of like, how much are you getting? You see, none of this is financial information. It's just your level, of success with the amount of activations that you have. So I'll pause there because that's a lot of talking, and just see if anybody has any questions. And Gabby has the link up in the chat for those who couldn't QR code in if you need to get your attendance counted.
All right, any questions for Liz? Sorry, was someone about to?
Yeah, so Liz, I was talking to Jessica Mantooth in regards to getting our finance folks doing this, and I know that we had some great attendance on the last one. It's really just being able to take the time to kind of review the cases. The way she explained, I understood there was a pretty quick turnaround time that you wanted this to happen. Could you reiterate when you guys are asking for this information back?
Great question.
I thought it was November, but I cannot remember, and I just wanted to make sure that we had the right date.
Yeah, I think for that I don't think we Gabby, do you remember if we sent out an email when we wanted the 3 months collected? We wanted a couple test cases for the folks to just go through it with a couple test cases for the for before the webinar, just so, you know, just so we could know, like, is it working or is it just too much, you know? And then, you know, we wanted folks before the end of the year to try to go back and we selected January, February, March, just thinking that that's the best chance that you will have had cases admitted, discharged, and billed, you know? But folks have already asked me, well, you know, we either switched EMRs or we switched to billing software, of course. You know, we'd love to have the same time frame, but I think if it's easier for you to get a full representative month, but it might not be the same month, I think that's probably okay too. But I think we're probably going to target before the end of the year. And that's why, again, we allowed a sample percentage, because I know, Angela, with your volume, you know, it might be a little bit hard, just depending again on where your folks are with this. So I don't want to make it super complicated, but I do foresee having to re-engage TCAA to do more education with this. And then, of course, next steps are we want you to go back on the claim and then figure out, did the insurer actually give you an allowance for that? You're not going to know how much money it is, but they'll say yes or no whether you got it. And then we got to collectively figure out, if we're getting a lot of no's, why are the no's? So this is really just the first part. So do you think the end of the year is reasonable? I mean, we're already at the end of October and we're getting holidays.
I think so. They're not pushing back on us yet, but she's going to have another meeting with them earlier, actually this week, just to ensure, because I mean, I'm actually fascinated by the information that they provide back, because I know that we went on this journey a couple years back. So I'm actually interested in seeing it to make sure that we are collecting what we can collect, or at least billing from that perspective. We've been told we are, but I think this will be fascinating for us to kind of take a peek at.
Well, thanks for your interest. I appreciate it. And, you know, I think collectively as a group, because you're all probably working with the same insurers, right? Wouldn't it be great if we're all on the same page and we say, you know, of this one insurer group, you know, X% of all of our centers, because you're all working in a group, and that's so powerful, you know, X% are being denied. What is the problem here, you know?
Liz, I pulled up the email and it was just in regards to the webinar, if they had any feedback or questions on the tool or part 1 of the webinar to submit by Friday, November 1st.
Okay, thanks, Gabby. Appreciate that. So Angela, maybe we'll just get consensus with the group to say, do you guys think you could bring it across the finish line with a sample of a quarter's worth of your data? Doesn't have to be everybody, because for some that volume is just, you know, insurmountable, but it should give you a sight line into where, you know, your issues are. Because again, we'd really, in case we get that question again, we'd love to have some, you know, this is great for us to show the legislators that we are doing everything we can to make sure that trauma fund remains the payer of last resort. And then once you have this information, I think it will then be easy to go do that other piece, which is going to be the home run, which is looking at the claim to see whether they paid it or not. Regina, you add anything about that and your struggles with your center and looking at the claims and seeing a lot of denials?
No, it's just getting the right people. The easiest thing, they gave me access to view only to the claims. So I was doing the reviews myself, which takes time. I think we're trying to get the right group together who can help. And we are in the midst of transitioning to Epic. And I know we're looking at, can we create, I'm sure we can, a report out of Epic that runs some of this data, so we can get the list of patients to get to finance, and then, you know, can finance run a report once we provide them with the list of names, so that there's less legwork. Just individual time spent looking up the patients to do it. I think we got to figure out how to automate it, because this is a good thing for us to do going forward, just charge reconciliation for trauma. And what does that look like? So that's the only challenge that I've had so far, is having to get access view only, run the list out of my registry, and then go one by one and view the claims to see where are the charges on there, and is the type 5 on there. I will say though, it was a great experience because I'm much more savvy at navigating through the electronic bill than I was before. So it was a good exercise.
Thank you.
All right, any other questions or comments for Liz around the finance worksheet? Okay, let's circle back to Gabby to review the FY26 performance-based pay work group. And Gabby, you may be on mute if you're talking.
I sure was. Sorry about that. So this work group came about by request of the GTC Finance Committee. They really wanted to get a group of people together to give recommendations on the upcoming PBP criteria for FY 2026. So I'm going to give you a brief overview, just kind of to let you know what's going on behind the scenes. For the work group scope, this is really to just provide recommendations on that criteria, on tiered metrics, and percentage of risk. We're looking at towards the end of December before the holidays to get those recommendations completed. And we have a great amount of representation on the work group. You have TPMs, administrator, burn, pediatrics, levels 1, 3, and 4 representation. So we're super excited to get some feedback from them. And this is the roadmap. So right now the work group is meeting. It's a group of 6 stakeholders. And then after we get those recommendations, we're going to do an open comment period, and that will be sent out to all stakeholders so we can get your feedback as well. After that, the finance committee is going to review those work group recommendations and the stakeholder comments. And the light at the end of the tunnel is Georgia Trauma Commission. They'll be meeting in February, and they're going to review and approve the FY 2026 PBP, and that will be implemented into your FY 2026 contracts. And some things we're going to be looking at is implementing tiered metrics that will resemble Michigan's PBP. So we want to sunset all or none approach for qualifying criteria. So you may have experience where one person doesn't attend a meeting and then you lose all the percentage for that PBP. So we're hoping to mitigate that. We're going to organize meeting attendance criteria by role and then introduce outcome measure metrics. And here's a little snippet. This is not finalized because we still have to go through the criteria itself of what it would look like. I'm going to zoom in because it's super tiny. So looking at trauma program manager participation, you can see if they attend 3 of the 4 meetings, they'll get that 5% allocation. These are test numbers, so the amount you get varies by organization. And if they attend 2 of the 4 meetings, you'll get 3%. If you attend 1 of the meetings, you'll get 1%. But if you attend 0, you'll still get that 0% at risk. One other thing we'd like to look at is reviewing the overall percentage at risk for each level. Right now, you can see level 1s and 2s are receiving 80% of their readiness dollars at risk. Level 3s are 60%, level 4 is at 19%, and burn is at 50%. One thing that has also come up is the ACS/ABA criteria requirements. So these are requirements that are already required by the ACS and ABA for level 1 and 2 centers. So we're going to be taking a deep dive at those and see if they're still helpful or required to include in the PBP. As far as timeline, so right now we're hoping to get those recommendations again done by the end of December. Open comment period looking at January. Finance committee will review it end of January, beginning of February. And then the commission will meet February 20th, I believe, to approve that PBP for next fiscal year. And the work group did just meet last week on October 23rd as the kickoff meeting. Our next step is to review the proposed criteria, then the criteria percentages, tiered metrics, and then finalize those recommendations. And I think that is it. Liz, Regina, did you want to add anything to that?
It was a great first meeting, and we do have a lot of good representation, and we definitely need to hear feedback on this. I think for this group, that tiered attendance will really help, because in the past we had bundled like those big GQuip meeting day, meeting, when we're off-site, and at those meetings where we have all the committee meetings, then GQuip and then GTC. Like if one person doesn't go, you're really sunk, so we want you to come. We really need everybody at the table, but it's a little too much, heaviness on having the whole group together. So we think breaking that up will really help. That being said, there needs to be enough at stake that it's still important that we don't just, remember back in the old days, my facility, they would say, oh, we'll just forego that portion of it, of the money, and not attend the meeting. And, that's certainly what we don't want to do. So, we'll give plenty of notification when the open comment goes out. And we really need folks' feedback to make sure that we, maintain the intentions of this, and that, we're focused, everything is focused where it needs to be. And then ultimately, the commission will approve it based on what the finance committee's recommendation is, based on all the feedback that we get.
All right, any questions for Gabby or Liz? So our last order of business is to take a look at our 2025 proposed committee meeting dates. I can't believe we're already here, but we are. Of course, we've already talked about the fact we've got our, part 2 of TCAA finance coming up next week, and then we've got the trauma, the full commission meeting in November. But that's it for this year, and so it's already time to look forward to 2025. And the first meeting would be the in-person meeting that's part of the GQuip in-person meeting. And this, for many of us, is that part of that required attendance that we were just talking about. And then you see the rest of the dates there in May, August, and then again in November. All the rest of them after February would be virtual meetings. So any immediate concerns about the dates? So are we voting on these today, or is this just us? Yeah, we need to vote on these.
Yes.
All right. If there are no immediate concerns, does someone have a question or comment? Sorry, I thought I heard someone. So if there are no immediate concerns about the proposed dates, then I will take a motion to accept these dates for our 2025 Trauma Administrators Committee.
This is Angela, motion to approve.
This is
I've
Becky. I
got it.
second that motion.
Okay, I've got a motion and a second to accept the proposed dates for 2025. Any discussion?
To get started, Builder Trend recommends using the Chrome browser.
If not, then all in favor, please say aye.
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 Aye. Aye.
And any opposed? All right, the motion carries. Thank you so much. Please go ahead and populate your 2025 calendars with these dates so we can all be on one accord. All right, that pretty much wraps up our meeting in terms of any action items. I guess the main thing is just, the finance worksheet that Liz, reviewed for all of us. Circle back with your teams and ensure that they are they have the information that they need or access to the information that they need to be able to complete those worksheets so that they can, get the most out of the finance, webinar, as well as, of course, the data that it's going to be providing to us. I don't know that there are any other action items. Liz, Gabby, anything else to add?
I think that's it. We covered a lot in a short time today.
Dr. Walker, can I ask a clarifying question? Is Gabby going to send us the invites like she normally does for those administrator meetings? I
Yeah.
heard you say for us to populate. I just want to
Oh,
make sure.
sure. Yeah, she will. She will send those. She will send those out. Yeah.
Thank you.
Any other questions, comments? All right, very good. Well, then I will adjourn our meeting. What time is it? 10:37. Thank you all so much for your attendance and have a great rest of your day.
Thank you.
Thank
Make
you.
sure you
Thank
sign in
you.
also for those that didn't sign in at the beginning.
Thanks, Dr. Walker.
Thank you. Have a good one.
You too.